All right. Well, this is really, actually, this should be a fun episode because I think it's an important topic on Healthcare Unfiltered about screening, early detection of cancers. It's a topic that, frankly, a lot of listeners and viewers ask about. And there are some real things that are supported by data in what we're doing, and sometimes a lot of things being done without data. But to separate myths from facts, we have two amazing guests today that will introduce themselves, and we will dive right into it. So, Lecia, we'll start with you and just to tell folks a little bit about what you do, but more importantly, your involvement in the kind of early detection space and things like that.
Yeah, thanks, Shadi. Thanks for having me back to your podcast. So my name is Lecia Sequist. I'm a medical oncologist at Mass General Hospital in Boston, Massachusetts, and um, I'm about 20 years into my career now. And the beginning of my career was very typical for medical oncology, where I focused on clinical trials and new drugs to treat patients with advanced cancer mostly. And I enjoyed that space for quite a while. But about 5 years ago, I started wanting to try something new and got very, very interested in early detection and have now actually switched my entire research focus away from clinical trials and drug development into the early detection and screening space. I focus a lot on lung cancer because that's my clinical area, but I'm interested in early detection for all types of cancers. And the reason why I made that personal switch is just because of the increasing number of technologies that are coming out, I think that are helping us figure out ways to find cancer at an earlier stage in more people. And I think the changing face of many cancers, we had these paradigms from the last century, which told us who was supposed to, be the highest risk type of patient to get certain cancers. So, for example, someone who used tobacco, that's who you would think of might get lung cancer, or just in general, that people over 65 were the ones who really got cancer. And we've all seen how cancer is shifting, and younger people are getting cancer, and people without those traditional risk factors from the past. So we've really got to study this. We've got to understand better who should be screened for what types of cancer, and so we'll get into that, but that's essentially why I shifted my focus, and I'm so happy because it's interesting and it's a new challenge for me, and it's a challenge for healthcare, and I think it's really connected to people in the community, real folks.
Well, I'm happy you're doing it, and it's the right person to invite, obviously, on the show to really address these issues. And you're right. I mean, I think there are so many things that need to be a little bit explained. And given the fact that you did clinical trials, you've taken care of patients and things like that, you hopefully can separate signal from noise. And we have a newbie on Healthcare Unfiltered today, Jeff Yang. Tell us about you a little bit.
Great. Thanks so much for having me. So I'm a thoracic surgeon at Mass General, and I spend a lot of time working in the community to raise awareness about lung cancer screening through the American Lung Cancer Screening Initiative, and also working on prospective study of lung cancer screening for Black women who are at risk of developing lung cancer. In general, I really care about early detection for many reasons. One is because the reason why I wanted to be a doctor was actually because my grandfather was diagnosed with lung cancer when I was in college, and I helped take care of him. And unfortunately, his lung cancer was discovered at a later stage, and it's always been big regret of mine that he wasn't able to see me graduate from medical school. I do feel that if we had caught it early, lung cancer screening wasn't available back then, but I do feel like if we had caught it early, I still may be able to talk to him today. And so it brings me a lot of joy to be able to help patients, and especially when we can find their cancers early through lung cancer screening. But this is a big issue right now in the country because only 5% of people who are eligible to get screened are actually getting screened. So that's a little bit about why I'm really focused on this area.
Yeah, thanks, Jeff. So there's an initiative now. This is like a countrywide initiative by which society? The American Cancer Society, or by who?
Yes, so this is a nonprofit, the American Lung Cancer Screening Initiative. We're very grateful to have Lecia be one of our advisors for that. And it is a nonprofit that is really driven by students and their passionate commitment to teaching people about lung cancer screening in different communities. They can range from underserved communities to, I remember one time we were giving a talk to really fancy country club that Helen Mirren was there asking us a question about lung cancer risk and lung cancer screening. So, but mostly we do focus on communities that don't hear about lung cancer screening. And right now, this American Lung Cancer Screening Initiative nonprofit is um, being housed, I guess you could say, in 50 different university campuses. So a lot of students from all across the country, from the West Coast to the East Coast, to big universities and big sports towns, to small cities and small towns as well.
Well, that's, as they say, you get a celebrity to advocate for you. I think you reach out. But Lecia, what's the recent, do we have recent up-to-date information from eligible patients for screening? What the percent of those is it 5%? It's that low?
That was the most recent published data. I was just at a meeting where I heard kind of through the grapevine that some newer data is looking more promising, but by more promising, they're talking it might be 18 to 20% now. So it's still fairly low, but that newer figure I haven't seen published yet. It's a little bit of a moving target because the eligible population expanded quite dramatically in 2021 with an update from the USPSTF, the U.S. Preventative Services Task Force. They're the people that make the most definitive guidelines about who should be screened. So they broadened their eligibility for lung cancer screening in 2021. So a whole bunch more people became eligible. But it does seem like things are starting to move in the right direction. But lung cancer screening uptake is way below colon, breast, cervical, the other standard screenings.
Mm-hmm. Yeah, I noticed that. Actually, you will hear about this, but you see here in my background, there's a cancer journey. This is a book that I wrote. It's coming out in about, we're taping this late August, coming out in late September. And there is a chapter on this, on cancer screening, and I talk about lung cancer screening as well. And as a non-thoracic oncologist, I have to share this with you so you could just shed some light, because I think some folks will be as confused as I was when I was researching the topic. It has changed. I did, like Lecia said, the recommendations changed from the original study that was published and things like that. And it was never clear to me, why was it, how did we get the 3 scans in a row and then you don't need to get the scans after a third time? I guess the original screening, you do 3 years, right? And then up to age 75, I believe it was. And you had a percent, a smoking year with it, probably 20 or 30, I forgot. And so, Lecia, was this determined because you have to do inclusion-exclusion criteria for any trial? You can't really have it. Or was there biology and science behind it?
Yeah, a very insightful question. This was literally about feasibility and accrual for a clinical trial. So that original pivotal trial that first showed a survival outcome benefit for lung cancer screening, that study is called the NLST, and it was published in the New England Journal in 2011. And the eligibility criteria for that trial formed the original eligibility that USPSTF went forward with. But so I mean, it was great that it happened. It was great that screening became endorsed. But I think it was, in hindsight, a little bit unfortunate that the eligibility criteria for the trial I think they were just around feasibility, not around scientific biology.
Okay, and I mean, sometimes you have to do this. So again, and Lecia, just sticking with you just a little bit, a lot of pushback for screening world happens is that, you know, could we suffer from overdiagnosis? I mean, that's usually what people are afraid of. And I mean, Jeff is a surgeon, so I mean, it's no easy feat to have something and you have to go in and remove it, and there are complications and things like that. What are you telling people now in terms of screening? Are we confident that screening, does it reduce overall mortality? Does it, I mean, what is the actual data that exists now for CT scans?
Yeah, I mean, these it's never clear cut, and there are pros and cons to screening, and you do have to go over that with someone who you're counseling to get screened. You have to tell them that there's a risk of a false positive and that they may go through some emotional ups and downs and some extra scans before figuring out that a nodule that's seen is actually not cancer. But when you look in a randomized trial at the number needed to screen in order to save a life from cancer, the lung cancer low-dose CT scans actually stack up quite favorably compared to colonoscopy and mammography. You have to screen way fewer folks in order to save a life for lung cancer screening than you do for some of these other screening modalities that Americans are rushing out to get in mass. So it is a very effective screening tool. But I think one of the main problems with the eligibility criteria are that they miss a lot of folks. And Jeff's research has focused a lot on how it systematically underrepresents Black people. So he could tell you a little bit more about that. But from my perspective as a medical oncologist, the patients that we see in our clinic walking in the door with stage 4 lung cancer, so they're clearly at risk for lung cancer. They already have the disease and it wasn't caught early. It's metastatic at this point when I meet them. Over 50% of them would not have qualified for screening, even if they had known about it or wanted to get it. So clearly the eligibility criteria for screening are not quite aligned with who's getting the disease in today's world. So, it doesn't account for people under 50. It doesn't account for people who have a moderate or low or never tobacco exposure. So we're missing the mark.
Interesting. So Jeff, I mean, maybe you can highlight in your experience and when you see what's going on through the program you're running and others, what have you seen the issues that are preventing, like what are the barriers? How much of it is really simply knowledge education versus, I don't know, cultural barriers, I guess? I mean, I'm trying just to think through why are people not getting screened? Tell me what your thoughts are.
Yeah, those are great points that Lecia brought up, and also a very important question, Johnny, that you had. I'm gonna go back real quick to what you were talking about, overdiagnosis. So usually overdiagnosis, this occurs if you have an increase in the incidence of early stage disease without significant decline in late stage disease that's discovered. That's the definition of overdiagnosis when you look at it nationally.
Like when we started doing PSAs, right? When we started doing PSAs, we had all these guys with early stage prostate cancer and no decrease in late stage prostate cancer.
Yeah, exactly. So when you look at it epidemiologically, that's the classical definition of overdiagnosis. Just a whole bunch of early stage disease that's discovered, but no decline in late stage disease discovered. The good news with lung cancer screening is you don't have that at all. So you have a very strong stage shift. So basically, you have more early stage disease that's discovered, and you have lower rates of late stage disease that's discovered. This is well documented in the real world by several studies, including one by our team, led by Alex Potter, and published in British Medical Journal a couple of years ago. So that's the good news, Chadi, for your question about is there overdiagnosis in America? There definitely isn't. And then going back to your question about barriers, there are many different barriers that we encounter. I think that one is that primary care doctors are often the ones, or primary care providers, so nurse practitioners, PAs, they're often the ones who order lung cancer screening for patients. And often we see that they're just too busy. The doctors, they only have 15 minutes to get stuff done, and it's not on their schedule or things to do list. So that's one reason. Another reason is the lung cancer screening criteria. They're quite complicated. So it's 50 to 80. You have to have smoked greater than 20 pack years. Pack years is in itself a calculation combining how many cigarettes you smoke a day versus how long you've smoked. And then you also had to have smoked within 15 years. So you have to be actively smoking or stop smoking within 15 years. That's quite a mouthful for any primary care doctor to have to calculate and capture. And I think there's also a lot of barriers when it comes to having to take time off to get this lung cancer screening. There's stigma. So a lot of people who are eligible to get screened can feel the stigma of disease. And also some people have what you call fatalism. So they think that what's the point of screening if I'm just going to die of lung cancer anyways. So there's a lot of good news to address all these things. One is that if you catch lung cancer early, it's way more treatable, way more curable, and a lot of people have the ability to live very long and healthy lives after that. Lung cancer screening is quick and easy. It only takes 2 minutes. It's much easier than a colonoscopy or a mammogram. And it's painless. It's covered by Medicare. It's covered by private insurance. And so that's definitely helpful. And then I think that we're trying to raise awareness. Our fields, everybody who's involved with lung cancer screening, from primary care, pulmonology, radiology, medical oncology, radiation oncology, and surgery, everybody's trying to raise awareness. And so hopefully, and Chadi, I think ultimately it does come down to awareness. Does everybody know that lung cancer screening is available to them? Or, among the provider population, do the providers know that they need to be ordering this? And I appreciate you for featuring early detection in lung cancer screening, because that's a really important step to trying to get more people screened for lung cancer and overcoming barriers.
I do think provider education is critical here. Like if you think of the typical relationship between a physician and the patient, if trust is established, it is very unlikely in general to go against the recommendation, right? Colonoscopy is an invasive procedure. It's an awful liquid to drink if you drink it. And it's definitely not a CT scan, right? And the uptake is much higher. So I wonder if some of your efforts, Jeff, is directed not just to the patient population, to the physicians and the providers taking care of them. And we all know that physicians are not always the easiest to change their mind about certain things. So that could be a very tough feat for you.
Yes, well, we're definitely trying to work on primary care outreach and to teach doctors about that. I was working on a proposal recently, and we just informally looked at some of our own Mass General data to try to figure out why people who were eligible, why they weren't getting screened. And half of those folks just noted that it just was never mentioned to them. In the primary care doctor's visit, it just was never mentioned. So I think primary care outreach is really important.
And I have to say, you could automate certain things. I can't tell you how many times when you take care of patients, sometimes they will Epic. It will just like you order a drug A and you get a screen. No, you're gonna order the other one. You can like automate. So I think I hear you about it's a mouthful of requirements, but frankly, if you are using the electronic health records and you're inputting the data, essentially there's a way where things could pop up, right? I mean, we should leverage technology to get that done, I think.
Yeah,
And one of the
absolutely.
best, yeah, I agree. One of the best ways to influence clinician behavior and hospital system behavior is with quality measures that they're held accountable for. So there's a whole group of people that are advocating for lung cancer screening to become a HEDIS measure. This is a quality measure that hospitals are held accountable for their primary care population, and it's all the things that are recommended for chronic health management, like screening for diabetes and controlling high blood pressure. And if lung cancer can get onto that list of quality metrics, I think that the numbers will go up.
I still think the biggest barrier, what I hear, is that these screening CAT scans for lung cancer has not reduced overall mortality. It may have reduced lung cancer specific mortality, but in a screening, to recommend screening broadly, you have to reduce overall mortality. Has this been shown to reduce overall mortality now?
Yeah, in that pivotal study that we mentioned from 2011, the New England Journal, the National Lung Screening Trial, there was a 6% improvement in overall all-cause mortality. And so with the very first large randomized trial that was shown, there are some other smaller randomized trials from Europe that have not been able to demonstrate that were significantly smaller in patient number than the U.S. study from the NIH was over 50,000 subjects. So that one did show a overall survival advantage.
And then let's just to how often they should do the CAT scan? Because when we look at breast cancer as an example, as you know, I mean, the recommendation at least until 75, and then you could slow
Yeah.
down. But is this still that you do it every year, every 2 years, or?
Yep, right now it's annual, up until age 80, or unless they're not, unless they have other competing comorbidities that would make it difficult to treat a cancer diagnosis. But
You start at 55
it's now down to 50.
to 50. So,
I personally think that may not be the right way to go, is everybody gets the exact same recommendation, but that's how the trial was done.
and you mentioned honestly something really, really important because, hey, you both are the experts, but everybody knows that there's a percent of patients who get lung cancer who've never smoked. Um, I mean, what do we just say it is what it is, or is there any way to like what do you say for these?
Yeah, well, that's one of the things my research is really focused on right now, is trying to understand who's at risk for lung cancer, because the current guidelines are focused on people who are perceived to be at risk. Risk is defined by tobacco use in that case. But in modern lung cancer, air pollution is a huge cause of lung cancer, we believe, and there's probably more genetic factors than have been appreciated in the past. Just because we haven't found the one magic gene that's analogous to BRCA, family history is a very, very strong risk factor for lung cancer. So, I think we need to have a better way to understand who's at risk, because it's not feasible and it's not affordable to have every adult screened every year for lung cancer. It's probably not necessary if you're at low risk, but you can't just automatically assume you're at high risk and you're at low risk just based on tobacco exposure. So I and many other people are trying to develop ways to actually judge what someone's risk is so that we can screen the people who are at risk, and it can be personalized. Just like when you get a colonoscopy, your first one is supposed to be at age 45. And then if there's polyps that are detected, lots of polyps, you might need one in 3 years or 5 years. But if there's no polyps detected, you're good for 10 years. And we need that kind of an algorithm for lung cancer screening too.
That would be great. That would be amazing. And I mean, hopefully next time we talk, there's some progress in that because that's actually key. But I mean, as you know, there's another test now that's like, it's becoming very popular. I mean, well, I don't know how popular it is because I don't have the stats, how often it's used, but it's a blood test. Who needs a CAT scan? I'll just do a blood test and I figure out if I'll get lung cancer. Jeff, right? I mean, that's all I need to do.
Yeah. Yeah, I think eventually that would be amazing if that's all you need is a blood test. That's probably what a lot of the field is working on for the future. And uh, maybe even before then, though, you still need to combine the blood test with the actual CT scan to get some more information. But it's an exciting area of development for sure.
Lecia, what are your thoughts about these, like, I mean, MSEDs, multi-cancer detection with liquid biopsies and all of this going?
Yeah.
Because essentially, I'll tell you my worry, but obviously I want to hear from you as the expert. I mean, is this part of your research as well, looking into?
Yeah, it
Tell,
is.
tell, tell me a bit about that.
I mean, so there's many, many technologies that are being developed. Some of them are disease specific. So, at the time of our recording this, just last week, the FDA did approve a new blood test for colon cancer screening. And there is one that is being developed specifically for lung cancer screening. But then there's also what you're talking about, multi-cancer blood tests, looking for several cancers with one test. All of these tests are or at least most of them that I'm aware of are looking at tumor attributes that can be found in blood, usually on DNA, and looking at algorithms to try and determine if a piece of DNA that's floating in the blood is derived from a tumor cell, a malignancy, or is it derived from some, healthy liver cell or healthy colon cell somewhere. So there's lots of exciting technologies being developed. I think they do have some downsides. So you have to have a tumor that's of a certain size or has a certain kind of biology that sheds DNA in order to be able to even pick it up in the bloodstream. And it may be that stage 1 tumors are a little harder to pick up, and certainly widely metastatic stage 4 tumors are a little easier to pick up in the blood. We've already seen that in the cancer world, and it's kind of a common standard of care now to look for tumor genotyping through the blood, which is an analogous technology. But trying to have the technologic know-how to find a tumor that's only, an inch in size or a half an inch in size, it's a large ask, but it is I think really advantageous if you can screen for multiple cancers at once, especially when so many tumors don't have a proven radiology-based way to screen, ovarian cancer, pancreas cancer, esophageal cancer, liver cancer, stomach cancer. There's so many cancers we don't screen for. We really only screen for lung, breast, colon, cervical, and sometimes prostate. So, all the other cancers are out of luck right now. It's great idea, but I think the technologies that we're dealing with in 2024 are still kind of the first generation ones.
But for the tumor-specific screening test, let's focus on the lung cancer just for a sec. I mean, essentially, doesn't this tumor must have a particular mutation or biomarker that I'm looking at? Like, I'm assuming, I mean, let's take 100 out of 100 patients with lung cancer. How many of these 100 would be driven by a particular mutation anyway? It's still the minority, no?
Yeah, no, that's a great question. And so the screening tests do not rely on looking for those driver genotypes like KRAS or EGFR, which is more what we do in the metastatic setting to choose treatments. The screening tests tend to look at more of a global characteristic in the DNA that distinguishes tumor from normal. So, the multi-cancer detection test that's already on the market is made by a company called Grail, and their technology looks at methylation patterns. So the methyl groups that are stuck on the DNA have a different pattern in malignancy than they do in healthy cells. And the blood test that is being developed for lung cancer screening in people who've smoked is made by a company called Delphi. And what they're looking at in the DNA is the size, the fragment size of the DNA chunks that are circulating, and the size is much more erratic and all over the place in cancer and much more uniform and small from healthy cells. So they're looking at these kind of global characteristics instead of a specific mutation calling.
Okay, but usually if I do the test, you'll be able to tell me my percent of developing the particular cancer. You're not going to be 100% sure. You're going to tell me I'm at 80% risk of developing the cancer within 5 years type of thing? Is that how I should be reading it?
Yeah, no, the blood tests do not tell you a risk for future cancer. What they're trying to do is detect a cancer which you may be walking around with now, unbeknownst to you. But they are screening tests. They are not diagnostics. So getting a positive screening blood test for cancer, say on a GRAIL test as an example, that does not equal a diagnosis of cancer. It's like having an abnormal mammogram where you would have to go through a biopsy and maybe an ultrasound first and then a biopsy. And a lot of the times a biopsy doesn't show breast cancer. It's just, fibrous tissue. Same thing with these blood tests. You can have a positive signal come back, positive screening, but yet further analyses and further biopsies do not show cancer. And, I think that's one of the downsides, at least with the multi-cancer tests that are out there, the true positive rate is less than 50%, for example, for the GRAIL test. So, you give the test to 200 people and about 3 of them will come back with a positive signal. So the vast majority, you have no
Right.
signal of cancer. Doesn't prove they don't have cancer, but it's I guess a good sign that there's not a very active cancer that was picked up. 3 people that were positive, only one of them really will have cancer, and 2 of them, or about 40%, will be a false.
Will be false positive.
60% false positive, 40% true positive.
Because once you see there is the blood test is positive, the next step obviously is a CAT scan. I mean, to find something. Sometimes you see something, sometimes you may not, because the test may not be, I guess, could be false positive.
False positives,
In
yeah.
the false negative ones, so let's say the person has a blood test and they're false negative. Must they repeat the test annually, every 6 months, every 2 years? Do we even know that negativity, how long does it give the patient security for?
Yeah, it is just a one-time look at what's happening. So if you really wanted to go into a screening program for a specific cancer or for multi-cancer, you would have to do it at an interval. And I think a lot of the companies, are planning for a test that would be repeated annually. But I think that the truth is we really don't know what the exact right, interval is yet. There's a randomized study being done in the UK that looks at this test from GRAIL annually for 3 years. And so I'm interested to see the results. Half of the subjects are getting the test, half, along with standard of care screening, and half are just getting standard of care screening. And they're looking to see if cancers that are diagnosed in the 2 groups, if there's a stage shift, if you're seeing earlier stage diagnoses because of the addition of the blood test.
And you're going to need thousands of patients. I mean, for something like this, you need like tens of thousands.
Exactly. It's thousands of patients in the National Health System in the UK.
And Jeff, Ivan, we talked about this a bit earlier, but obviously one of the major concerns is that, if you detect something and you're not sure if it's cancer, then you as a surgeon have to either take it out and biopsy it, like if it's a nodule. And as Lecia just said, there's a 60% chance that this may actually be nothing. So you're taking out a benign nodule, whatever it is. We don't know. I mean, maybe it's plus minus 10%. But for folks who are not surgeons, what is the real morbidity? Like, can you give us some percentages What is my likelihood of a, lung collapse? What is my likelihood? Like, what is the real deal in terms of actual complications that nobody wants a needle in their chest? I'll be the first to say. But if I need to have it, I'd like to know what the percentage of something bad happening.
Yes, I think you raise a really good point, because you had asked about barriers earlier in this podcast, and I think one of the barriers that still exists is that even doctors themselves are worried that lung cancer will lead to a lot of harm. And the good news is that it isn't. Lung cancer screening is actually very safe. So in terms of some percentages, I think it's, first of all, really important to know that among patients who do not have lung cancer, but who undergo lung cancer screening, the rate of major complication is 0.04%. That's from the really big trial, the National Lung Screening Trial. So that is 0.04%. It's almost 0%. Now, for people who are undergoing lung cancer screening, there is, and who get, for example, who have a false positive, that meaning that it was the CT scan showed that, hey, this is concerning for lung cancer, and then they eventually actually got a invasive procedure like a needle biopsy or surgery. Among those folks, the complication rate is still very, very low. It's 0.1 to 0.2%. The number of people that have to get any kind of invasive procedure from lung cancer screening is also really low. It's about 1 to 1.8%, 0.9 to 1.8%. So I think that this is all to say that lung cancer screening is very safe, and that I do feel, Chadi, you bring up a good point, because there continue, even in 2024, there continue to be either newspaper articles or editorials or opinions or even studies that keep talking about these concerns of harms of screening that I think are incorrect and inaccurate, and so it's.
Jeff, the one thing I will say, and again, I don't know, I have no data. I just want to push back a little bit, because you obviously work in a major academic center, one of the best in the world. You have the expertise, all of that stuff. I wanted to assume that this may not be the case in terms of surgical talent, surgical capabilities, surgical support in the rest of America. So the concern becomes is that, if somebody is going to detect this in a small place where the resources that you have, they may not have, we really translate the percentages you give us to these lower resources states or counties or things like that.
Yes, I do feel like in 2024, thankfully, as you know, with each decade, care continues to improve. And the same thing goes with diagnostic procedures and also with surgery. And but for example, there have been at least 14 studies that I know of that have looked at what is the percentage of people who needed to get a needle biopsy for a false positive result. And that ranges from 0.09% to 0.56%. And it doesn't just look at Mass General or major academic centers. It's looking across the spectrum. So it's I think the numbers are just very, very low. And I guess I'm thinking about why it's so low. I think in general, radiologists from any hospital in the country, if you're board certified to do a biopsy, you have to be good enough to do one safely for lung nodules. And
so the complications then are not as high as some people might really mention.
I There are a lot of nodules, and that's different than biopsies. And I think it's a little bit of a different mentality between lung cancer screening, not mentality, it's a different procedure. You know, when you get a mammogram, the baseline thing, whether you're at an academic hospital or community hospital, if there's an abnormality on the mammogram, they're almost always recommending biopsy. That's because biopsy of the breast is generally low risk. Just the way that mammograms evolved and the politics around breast cancer screening, women want to know, and they want to know ASAP. So there are a lot of negative breast biopsies that get done. I'm sure many listeners can relate to that. Lung cancer, when we see something in the lung, the threshold of wanting to stick a needle in it is a lot different because it's an air-filled organ that can have an air leak, and that's a big deal. So what happens a lot with false positives in lung cancer screening is they get more scans, and we sort of see what happens over time. And I think for people to actually stick a needle into it, it's actually a very low rate. And that's part of why the complication rate is so low, as Jeff is saying.
And Lecia, I don't want to go into a class of statistics because you will take me to school with this, and I don't want to really. But I want to go back to the blood thing. How do you balance sensitivity with specificity with a test like this? I mean, honestly, because it's almost mathematics here. I mean, you clearly will never get 100% on both sides, right? I mean, it's just not going to happen. So how do you even, like, what should I be looking for? Do I want a test that is 100% specific? Because that's going to compromise my sensitivity. Like, tell me, how do you think about as a scientist that is immersed in this field?
I think this is something that Jeff said earlier too, is that we can't count on one test to be everything. Tests are used in pairs and in combinations. And if we are trying to screen a large number of people and find as many cancers as we can, we want a test that's going to have some false positives. You know, you have to cast a wide net and then narrow down with further tests. Just having one positive blood test or, you know, one CT scan with a nodule on it, it doesn't mean you have cancer. It means there's some suspicion that's been raised, but further study needs to be done. Maybe it's a positive blood test leads to some kind of CAT scan or PET scan. A lung CT with a nodule leads to a follow-up CT with a nodule, follow-up CT to look and see if it's changed a couple months later. So, you know, we can't expect an answer, you know, the same day. A lot of times these screening tests lead to more tests. But I think understanding who's really at risk for cancers is also one of the keys to making these technologies work better, because you can have a blood test that has a set sensitivity and specificity. Maybe they're really high. Maybe they're, you know, great, 95% sensitivity, 95% specificity. But if you administer that blood test to a classroom full of kindergartners, none of whom have cancer, every positive you get is going to be false positive.
But
So
that's my concern about the MSED. You know, my concern is, and that may be a nice topic for us to discuss and maybe finish off with. My concern is that this is a direct-to-consumer test. And I get it, but the reality is, I think screening should be supervised by a healthcare professional that really can counsel you and understand the nuances, right? So, I mean, if I can just go and get my test done without even calling you and asking you, I think it's an issue. Don't you think? What are your thoughts about that? I mean, because it is available. Like anybody can, I believe it's like 23andMe, right?
I mean, I think each company has its own different ordering specification. The Grail test, you do need a physician to order it.
Okay, that's good.
But there are, at the same time, the company has some APPs that if you don't have a physician, you can use their physician. So, but I agree with you. This does need to be tied back into the healthcare system. And each company is going to come up with its own model, and we may not like all of them.
So Jeff, maybe final thoughts into if we're having this conversation a couple of years from now, where do you think the world of screening is? You made a great progress from 5 to 20%. You're not going to get 100%, I could tell you that. But where do you want to be? Like, how do you, where do you see your efforts going and leading, hopefully, in the next couple of years?
I think that's a great question. So for colorectal and breast cancer and cervical cancer, the screening rates are around 70%, sometimes even 80%. And so for the lung cancer community, we're gonna try to really get up to those numbers. Probably won't happen in 2 years, but certainly that's what we aspire to. And I do think that, again, very appreciative of you helping us raise awareness.
We're going to see a bump. We're going to see a bump after this episode.
Yeah, exactly. That's very important, to just constantly, whoever's listening to this, please share with your family and friends that lung cancer screening is quick and easy, it's safe, and that really we actually did this survey of over 500 community members and who are in the college campuses, and over 40% knew somebody who was eligible to get screened. And so even if you're not eligible to get screened, you probably know a family, friend, or neighbor who is eligible. And so we'd love for people to help us raise awareness about that.
That's great. And Lecia, my question to you is, in the next few years, I mean, I'm really fascinated by the world of MSED. I'm not clear where it's gonna go, to be honest. Usually I have like I can't really predict where it's gonna be. Are you able to predict where it's gonna head, or you kind of just watching, but you're more immersed? You're watching from the inside. I'm watching from the outside.
Yeah, I think that novel screening technologies are coming, and they're all going to be different, and it is complicated. And my spin on it is that I think specialists need to be involved. For a long time, screening kind of sat squarely within primary care, and primary care screened for heart disease, screened for cancer, screened for, domestic violence, screened for a lot of things. Super, super important. And especially for people who have a long-term, strong relationship with their primary. I mean, there's no better place to talk about screening, but not everybody has that. And I think if we don't start to take collective responsibility for cancer screening across the whole healthcare system, we're going to be leaving people out. And so I think lots of types of clinicians need to get involved, not just primary care.
I think if I may, I think what would be very interesting, what I'll be looking forward to learning from your research and the research of others, is what are we doing for the patients who don't fit that criteria that is for screening? Because I do think Jeff's efforts are going to be helpful in folks who meet these guidelines, right? I mean, you want to raise awareness, guidelines based on age, smoking, all of these things. If we complement that with the folks who don't meet the guidelines, I think, we have to have guidelines, unfortunately, because we don't have finite resources. I mean, you just can't do somebody has to pay for it, right? At the end of the day, somebody has got to pay. And if they're paying for this, you have to think about from a societal perspective, they're not paying for something else. I mean, so you always have to think, am I better off screening for lung cancer, or am I better off screening for hypertension and diabetes?
Exactly.
I'm just putting like policy hat from a society
Exactly.
perspective.
Yeah.
So it's a fascinating field to me. I think this was very, very helpful. A lot of folks will be very intrigued by this, and I look forward to having you back and learning more from what you guys are doing.
Yeah, thank you. And any of the listeners that are interested in learning more about what we're doing at Mass General in early detection, we do have a website for our Cancer Early Detection and Diagnostics Clinic. If you just Google Early Detection and Diagnostics Mass General, you'll see some of what we're up to.
Yeah, and I'll just end with a plug for Lecia's work as well, which is her team just published a paper in Journal of Clinical Oncology about Sybil, which is a AI model and tool that can predict an individual's future lung cancer risk from a single low-dose CT scan. So going back to Chadi, your last point about what does the future hold, especially for people who are not currently eligible to get screened under lung cancer screening guidelines. I think that that future will probably include Sybil and other advancements to really help that population.
I'm a big proponent of AI, so I'm all in for that. Doctors Lecia Sequist and Jeff Yang, thank you so much for coming on Healthcare Unfiltered.
Thank you.
Thank you very much.